Purcell, the project director, to go ahead and get started.
Thank you, Tricia, and welcome everyone. We're very glad to have you today to hear our presentation from Dr. Betty Lowe utilizing the You Are the Key presentation from CDC, but also talking about some best practices that have gone on. We're excited to have Betty here today because, more importantly of all, she has worked with our Louisiana AHEC, who provides training activities in the Louisiana area for not only health professionals but also residents, and has done an excellent job and comes to us highly acclaimed. For many of you who may not be aware of the National AHEC Organization, I'll briefly go over for you what it is. The National AHEC Organization is the membership arm of the National AHEC centers across the country in the AHEC network. There are over 300 AHEC entities across the country in 44 states. And the main purpose of AHEC is workforce. They provide a variety of programs and services to support the recruitment and retention of healthcare professionals with a particular emphasis in our rural and underserved communities. Many of the health professionals today, many of you as health professionals may have been trained at an AHEC or with an AHEC different activities, so we're glad to have you here. Our presentation today is jointly provided by the Postgraduate Institute of Medicine and the National AHEC Organization through our CDC project. And none of the speakers nor the planners for the event today have reported any conflicts of interest. Please remember to take advantage of the instructions, which are located, as Tricia told you, in the bottom left-hand corner. For you to receive your CME, there are credits for physicians and nurses, and then there is also a generic certificate available if you need those credits and you're in a different health profession and can utilize those credits. That information is provided for you. Be sure to download that information, follow the instructions on the very back page. If you have any problems, be sure to reach out to us. We'd be more than happy to assist you. So with that, it is my pleasure to introduce our speaker. Dr. Betty Lowe is how we've been told all about her for the 3 years in our project, and this is our 4th year about what a great job she does in Louisiana. Betty works for the Louisiana State University Health System. She is a professor of clinical medicine and pediatrics and the director of the Medicine and Pediatric Residency Program. She earned her medical degree from LSU School of Medicine, internship and residency in medicine and pediatrics at the same institution, and she also was a chief resident in pediatrics. Since that time, she has received numerous teaching awards, was the assistant program director, and then, of course, became the program director after that. She does educational and clinical activities throughout the region and volunteers at several community service clinics and in community service activities. She is a board certified in internal medicine and pediatrics, a member of the American Association of Pediatrics, the American College of Physicians, and the American Society of Internal Medicine, and the College of Physician Executives, and the list goes on. As I said, we're very proud and excited to have Betty today. We've heard so many wonderful things about her, and we've, of course, looked at her presentation and know that it will be slightly different for those of you who may have had a You Are the Key presentation. But again, it will spotlight the best practices and how we can use HPV as cancer prevention as we work to improve rates across the country. With that, I'll turn it over to you, Dr. Lowe, and we're excited to hear your presentation.
Thank you so much, Gretchen, and welcome to all of you, and thank you for allowing me to give this presentation to you, and I look forward to questions that you may have at the end. Trying to advance the slides.
The little arrow in the left-hand corner, or we can do that for you.
Little arrow in the left-hand corner. So if you could, that would be great. That would be wonderful. So our objective today, as Gretchen had outlined, is to certainly discuss the burden of HPV disease as well as the updates on the HPV vaccination recommendations as per the CDC, the rationale for vaccinating our youth at the ages of 11 or 12, and to explain exactly through many of the fact sheets and the educational materials provided by the CDC, how we can hopefully try to increase the vaccination rates amongst our children, knowing that HPV is a leading vaccine now to help prevent cancer for both males and females. So without further ado, we're going to discuss HPV and understand the burden of this disease in our community. So this is a slide that I put up that highlights the importance of vaccination. So Edward Jenner, who was considered the father of vaccinology and even the father of immunology in 1796, he actually was the creator of the first vaccine for smallpox, which we know was officially eradicated by the World Health Organization in 1980, with the last case in 1977 in Somalia. But you can see that there was a worldwide effort to try to eradicate this disease, and for many reasons. And it's because we know that there was a 30% mortality associated with it and a significant comorbidity associated with it. So as you can see with these photos, this is exactly the type of disease that obviously made an impact amongst the entire world. And so eradicating this disease really put vaccinations at the forefront of importance to prevent disease in the first place. So when we talk about HPV, there are over 150 strains of HPV, but the strains that we're going to focus on are not the cutaneous strains that we know cause the common hand and foot warts, but it's the strains that have the predilection for the mucosal sites, including the genital epithelium. And so the highest risk strains include HPV 16 and 18, and these are the strains that cause the predominance of our cervical cancers, anogenital cancers in men and women, the oropharyngeal cancers, as well as cancer precursors. The low-risk HPV strains 6 and 11 causes 90% of what we know as genital warts, but also causes laryngeal papillomas and low-grade cervical disease that does not go on to progress to cancer. So again, just some photos. These are the common plantar warts that we're very familiar with that do not go on to cause significant morbidity or mortality. And oral warts, again, these are lesions that are typical of HPV. Oropharyngeal lesions that, again, may go on to progress to cancer if not treated. Genital warts, which I think we're very familiar with, that we may see commonly in our clinics. Laryngeal lesions that, again, could be vertically transmitted from the mother to the child and actually can go on to cause significant morbidity and mortality. So HPV will affect men and women. Most men and women are infected with at least one type of mucosal HPV at some point in their lives. Almost 25% of all Americans are currently infected with HPV. This is obviously the most common sexually transmitted disease in the entire world. There are 14 million new infections per year in the United States, and the infection is most common in our younger children and college-age kids in the early 20s. 50% of all these new cases occur in the highest risk groups, our 15 to 24-year-old children that we typically know are probably the highest risk for STDs. And that's why the screening for chlamydia and gonorrhea are occurring at this age group, 15 to 24. And up to 75% of HPV infections are occurring in this age group. So we know that HPV infection is an equal opportunity disease. It equally affects males and females. And up to 80% of people will have HPV before they actually turn 50 years of age. So the mechanism of spread, it is spread skin to skin, primarily during intimate sexual contact, primarily vaginally or anally. But you can also contract HPV orally or from just infected sex toys. And penetration is not needed. People can get more than one type of HPV. So if you have one strain, it does not mean that you don't have another. and it can be spread by someone who is completely asymptomatic with HPV to another unsuspecting person. So unfortunately, most people will never know that they have been infected. They will not necessarily have symptoms. So there is no cure for HPV. Prevention is the only key at this point. So we're going to obviously stress abstinence. We're going to stress that we limit the number of partners, monogamy, of course, and to always wear condoms, but that is not perfect because exposed skin can become infected. So even the perfect condom wearers are not spared of potential HPV infectivity. So immunizations is the primary way that we are going to prevent this infection. So if we look at the number of cancer cases that we are attributing to HPV by both males and females from 2010 to 2014, in the dark blue, the bars with the dark blue are representing the most highly infectious strains, the HPV 16 and 18, which causes the predominance of all of our cancer-causing strains. So if you take a look at the females, which is on the top half, cervical cancer comes to the forefront as the cancer that is primarily affecting women infected with HPV. But if you look at the bottom half with the dark blue bar, it's oropharyngeal cancer in the males that come to the forefront. So we're actually seeing vaginal, vulvar, anal cancers, obviously in females, but oropharyngeal affects both males and women, men and women, and we're seeing an increase in oropharyngeal cancers in both sexes. So the cancers caused by HPV per year. So I circled cervical cancer because 91% of our cervical cancers are probably caused by HPV. But I circled oropharyngeal. Again, only 70% are HPV related, but we actually see a higher number of total oropharyngeal cancers as compared to even our cervical cancers. And the rates of the anogenital cancers are certainly increasing each year as well. So the total number of cancers caused by HPV is 32,500, more females affected than males at this point. So when we compare the difference between HPV positive and negative oropharyngeal cancers, the risk factors are the differences. So HPV positive oropharyngeal cancers are usually occurring in our males, and it's men usually having many vaginal sex partners as well as oral sex partners, having sex at a younger age, infected with anogenital warts, and using marijuana. As compared to the HPV negative oropharyngeal cancers, we see those mainly in older men who are drinking alcohol, using nicotine, and have poor oral hygiene. So just more photos. This is unfortunately a sad case of oropharyngeal cancer that is very advanced. If we take a look at HPV-associated male cancers, between 2009 and 2013, we can see that this light blue line starts early in the 20s, but peaks in the 60s. So unfortunately, oropharyngeal cancer is a cancer that is affecting males of all age groups, and it's increasing in number. It's certainly a cancer that many of our dentists, oral maxillofacial surgeons are very concerned about in the United States. Even in Sweden, we've seen a surge of HPV-related tonsillar squamous cell cancer. So in the black line, we see that is HPV tonsillar squamous cell cancers, and that is increasing in time from 1970 to 2006, over a 30-year span, while the numbers of HPV-negative tonsillar squamous cell cancers are decreasing. The good news is that the survival rates for HPV-positive tonsillar cancers is actually significantly better than the HPV-negative tonsillar cancers. But the increase in the total numbers is certainly of concern. So this is a busy slide, but what you need to take away from this is in the left bar graph. So with all races combined, women have more cases of HPV-associated cancer, and that's because more women have cervical cancer. Obviously, men do not get cervical cancer. But if we take a look at ethnicity, we see that in females, both non-Hispanics and Hispanics are equally affected in females. And in males, the predilection is particularly for our non-Hispanic males. And that is usually because more non-Hispanic males are infected and develop oropharyngeal cancers. So cervical cancer is the most common HPV-associated cancer amongst women. It's the fourth leading cancer in the entire world. We have a 500 million new cases and almost 300,000 deaths worldwide in 2012. And it's unfortunate that even with the development of the pap smear, which has detected and prevented over 75% of our cervical cancers, we're still seeing up to 13,000 new cases, at least in 2014, and 4,000 deaths in the United States. We can do better. Even one death from cervical cancer is too many. And we note that 50% of our cervical cancers are occurring in women less than 50 years of age, and 25% of those are happening in women in their childbearing ages between 25 and 39 years of age. So cervical cancer is a cancer that unfortunately is affecting women both in childbearing ages as well as in older women. It's not sparing anyone at this point. So even precancerous lesions are a burden for our women. To detect low-grade squamous intraepithelial lesions, women are exposed to having to get colposcopies done, which are very painful and psychologically can be very traumatizing. We see 1.4 million new cases of low-grade squamous, and we see almost 350,000 new cases of high-grade cervical dysplasia, which can unfortunately go on to become invasive cervical cancer if left untreated. So these are just photos of genital warts, which can take many different forms. So the condyloma acuminata is usually cauliflower-like in appearance, but we can also have cervical warts that are smooth papules and subclinical presentations that on the right become overt later on if left untreated. So here's another photo on the left, subclinical presentation, hard to tell what's going on until you apply the acetic acid and that lights up. But then again, after a year or two, you might see the clinically overt condyloma, which is much easier to detect. So if left untreated, the condyloma can then progress to the right, which again can be cervical cancer or can just be a very severe case of the condylomas. It's impossible to know unless a biopsy is done. So if we look at the progression of HPV over time, it takes at least 8 years before a subclinical HPV infection on the cervix can progress to invasive cervical cancer. And you can tell with the top pictures with the cellular atypia that as you go from left to right, you see a normal cervix that progressively over time becomes more and more irregular in appearance, and on the right is invasive cervical cancer. So this is such an exciting vaccine. So HPV vaccines that were developed first in 2006, this is not the first cancer-preventing vaccine. Actually, the hepatitis B vaccine is the first cancer prevention vaccine. And that is a vaccine we give to our infants at newborn nursery and then 2, 4, 6 months of age. And so we never really, tell those parents that, hey, we're giving this vaccine because we don't want your child to develop hepatocellular cancer. But it is an infectious disease, hepatitis B, and the vaccine is used to eradicate hepatocellular cancer associated with hepatitis B vaccine. So this is the second vaccine that was created, a very novel vaccine that hopefully will eradicate all those cancers that we had just seen in the prior slides, and that is the hope for this vaccine. So when we look at this vaccine, the concern is that, will this HPV vaccine cause my child to develop HPV-related diseases? And that is just an impossibility. And the main reason why is because the proteins used are not only are they not live, they're not infectious, and they're not cancer-causing. It's made of proteins that resemble the HPV virus, but it is not the HPV virus itself. And the great news is that when you give this vaccine, the recipients of the vaccine actually produce higher levels of neutralizing antibodies than they would have developed had they were naturally infected with HPV. So the antibody response, the immunogenicity associated with HPV is very high, and this allows greater and hopefully longer lasting immunity for those who are receiving the vaccine. So again, the breakthrough vaccine was developed by Merck in 2006, and that was our quadrivalent vaccine that, again, 16 and 18, the most virulent strains that go on to cause over 60% of our HPV-associated cancers are in that vaccine, as well as 6 and 11 that causes, I told you, 90% of genital warts. Now we have the revolutionary 9-valent vaccine that was developed 8 years later in 2014. And that vaccine added 5 additional genotypes, which go on to provide further protection up to 10% for HPV-associated cancers. So we have a possible protection up to 73% of HPV-associated cancers with this new 9-valent HPV vaccine, which is so exciting. So this is just a picture of what this vaccine is now covering. Again, 6 and 11, genital warts, 90% coverage there, 16, 18, 63%, and then the additional 5 genotypes that are causing up to 10% of our HPV-associated cancers. So our updated vaccine recommendations, as per the CDC is now recommending that all of our children are routinely vaccinated at 11 or 12 years of age with the HPV vaccine. And the reason why is that many studies have been done looking at the different age groups. When is the most optimal age for this vaccine to be given? Based on immunogenicity studies, many of which were done, 11 to 12 years of age seems to be that sweet spot whereby the children actually had the most robust immune response. And so it almost makes sense, and the timing is perfect, because if you look at our ACIP recommendations for immunizations, 11 and 12 is usually the school entry age that we're also recommending Tdap and Menactra. So those 3 vaccines can be offered at the exact same time. Now this vaccine, although it can be started as early as 9 years of age, the recommendation is not to be given at 9, because we just said 11 or 12 years of age is the sweet spot where the immunogenicity is greatest. And so while we're giving Tdap and Menactra, this is the perfect timing to give the HPV vaccine as well. So this is the newest breakthrough, and this is a great contrast to the former recommendation as far as when and how often should the vaccines be given. So we said 11 or 12 years of age is the recommended age, but now only 2 doses of the vaccine are recommended rather than 3 doses. And this is hopefully going to improve or dramatically improve our compliance amongst our adolescents, because in the past with the 3-dose vaccine, our immunization rates have not been very optimal. Now the second dose of the vaccine should be given 6 to 12 months after the first dose. So remember, if your child is immunized between the ages of 9 and 14, then only 2 doses of the vaccine must be given. If you wait, then unfortunately we follow the 3-dose protocol. So the hope is immunize your children early, certainly before the age of 15, and only 2 doses will need to be given. So how did we deduce that 2 doses were just as good as 3? Well, we knew that after 3 doses of the 9-valent HPV, that the vaccinees had a 98% antibody response. And so we basically used the 2-dose vaccine series, and we found that the immunogenicity was just as good or even better. And we actually tested an older age group, which we knew immunogenicity was not even as good as the younger age group, and we found that they were definitely correlative and actually even better. So the conclusion was that the 2-dose series was not only efficacious, it would certainly become even cost-effective over time. So if 2 doses are just as good as 3, well then how about 1 dose? So, and this study was done looking at over 11,000 females between the ages of 9 and 26. And so there's 3 groups that were studied, group 1 getting 1 dose, group 2, 2, and group 3, 3. And what they found was pretty eye-opening because the results showed that in group 1, and this is the group that received only 1 dose, but it was the smallest group. This is the group that actually had the highest grade of precancerous cervical cancer, as well as the highest rates of invasive cervical cancer in comparison to the other groups, which had many more enrollees. And so the single vaccine definitely pales in comparison to the 2-dose vaccine and is definitely not recommended at this point. So let's go over the dosing schedule to make sure there's no confusion. So if you start a child before the age of 15, so this is 9 to 14 years of age, again, only 2 doses are recommended. The doses are separated by 6 to 12 months of age. So the first dose is now, the second dose is in 6 to 12 months. If you wait until 15 years or later, then the original 3-dose series is recommended. So the first dose is now, the second dose is 1 to 2 months later, and the third dose would be 6 months after the first dose. So this is very comparable, if not, it is comparable to the hepatitis B 3-dose series. So one of the main questions that many ask, if the second dose is given after the age of 14, so at 15 and later, do I have to now start the 3-dose series? And no, the answer is no, as long as it was started before the age of 15, and you can just do the 2-dose series. So if your child missed the 11 to 12 years, which is recommended by the CDC, then you can actually vaccinate your children, the females, up to 26 years of age, and males can be vaccinated up to 21 years of age. But males can actually be vaccinated through 26 years of age if they're in a higher risk group, including gay, bisexual, men having sex with men, or transgender males, and actually males with immunocompromising conditions, including HIV. So there are special populations that are included in this high risk, including those with decreased cell-mediated immunity or humoral immunity. And these include our HIV, our T or B lymphocyte deficiencies, malignancies, our transplant patients, autoimmune patients, immunosuppressive therapy, that these are the patients that really do require the 3 doses because of the potential decrease in their immune response to the vaccine. For children who are unfortunately have been sexually abused or assaulted, we would want you to begin the HPV vaccination as early as possible. So those patients are an exclusion and should be started at 9 years of age. So diseases that you would think would be potentially immunocompromising, but they do not require a 3-dose series are ones listed below. So our renal failure patients, sicklers, those with heart disease, diabetes, even the CNS barrier defects, cochlear implants, asthmatics do not require the 3-dose series. So again, if we look at the vaccine immunity over time, and this is currently still being studied, so we still have many studies in progress, we know that this immunization provides protection for at least 8 to 10 years and possibly even longer. So just to reiterate, both our males and our females should be vaccinated, preferably at the age of 11 or 12 years of age, You can start as early as 9, and we just said those who are sexually abused or assaulted should start at 9 years of age. The preference is to start this vaccine before our children become sexually active, and certainly to finish the series before they're 13 years of age, which is certainly very doable if these children just return for annual visits even. So administration, this is an intramuscular injection, so the best site and the preferable site is in the deltoid muscle. And again, we want to administer this at the same time that we administer the Tdap and the Menatra. We don't want to separate these vaccinations if possible. As far as storage, it's stored in the refrigerator. Please do not freeze this vaccine. So again, some preventative warts. So we don't want these warts. We don't want our children to have to even experience this. Again, very psychologically debilitating for many of our children and even adults. Again, perianal warts. And this is my mom and my daughter, so two different generations. Unfortunately, my mom was never able to get the vaccine. It was never available. But my daughter, who is now 18, and unfortunately we didn't have the availability of the 2-dose series, but she has received all 3 and is a very happy young lady. So if we look at risks and benefits of this vaccine, this is certainly, we would never want to administer a vaccine that had more risks than benefits. This is my son, and he's now 22, and he's received all 3 doses of HPV vaccine. And I did start at 9 years of age with him because as soon as it came out, I was really hopped on top of that bandwagon and did not want my children to be even, having to worry about genital warts in the future or even cancer. So if we look at vaccine safety, the good news is that we have many systems in place, and the CDC and the FDA, both groups are continuing ongoing surveillance, ensuring that this vaccine is safe. And so if there are concerns about vaccine safety, and certainly many people are concerned that we don't know what potential safety issues there may be, just remember that we have ongoing surveillance of this vaccine and of all the vaccines that are available to our children and our adults. So 90 million doses have been distributed in the United States since 2006, so we have a lot of vaccine safety information. Much testing was done before this vaccine was even licensed by the U.S. FDA, and these are just some numbers here that you can see that many males and females were studied before the FDA even approved the vaccine. So we have over 10 years of vaccine safety data. That's really important. It makes me feel better, certainly, and it's important to know that the most common side effects are the side effects we see in any vaccine, just pain, redness, and swelling at the site. Certainly we've had, some youngsters and even adults faint, but that's mainly because of the vasovagal response from just getting stuck with the needle. But we've never seen any adverse effects, i.e. definitely no neurological sequelae, certainly no death. But we definitely do not want to be giving this vaccine to anyone who has a previous allergic reaction to the Gardasil vaccine, anyone who is allergic to yeast, pregnant women, and those with serious acute illnesses. You should certainly wait to vaccinate any child with any vaccine when they are well or if they only have a mild illness at the time. So we know this vaccine is safe. The CDC and the FDA has reassured us that they're continuing to monitor and evaluate the safety of this vaccine. So we as clinicians can reassure the patients that if they have concerns about this vaccination, that there are ongoing surveillance and that currently this vaccine has a great safety profile. So one of the most important aspects as clinicians that we definitely are interested in is to look at the impact of the HPV vaccine over time. And so the early outcomes are the immediate outcomes that we see in the first few years. The mid outcomes may take decades to see an impact, and that would be the impact on our cancer precursors. But it's the late outcomes that take decades to prove that, yes, our vaccine is actually going to decrease the incidence of HPV-associated cancers. That is the outcome of our goal. That is the goal that we are trying to achieve with this vaccine. So if we look at the 3-dose coverage, and now it's only the 2-dose coverage, we can see that the United States has paled in comparison to Australia and United Kingdom. We only had a 33% vaccination rate amongst our girls and comparing to all high-income countries. So we didn't do a very good job. Compliance was certainly an issue. But if we look at the impact of this vaccine in the United States alone, we have observed those outcomes that we were hoping to achieve. So the early outcomes that we are hoping to see a decrease in just the prevalence of the HPV strains, the hope that we are going to see a decrease in the prevalence of genital warts. Yes, we have observed these decreases. And I hope that this vaccine would impact cervical precancers. And yes, we are starting to see that as well. So this is a recent study in the Journal of Infectious Diseases that was published in September 2017. And they looked at the prevalence of HPV before the initiation in 2006 and afterwards. And this is remarkable data. So within 8 years of introducing this vaccine in 2006, we've actually seen an overall decrease in the prevalence of the 4 strains of HPV, 6, 11, 16, and 18, in that first Gardasil vaccine in 2006. We saw an 89% decrease in those 4 strains among sexually active women that were 14 to 24 years of age. But in addition, we actually saw a 34% decrease amongst unvaccinated women, and we're thinking that's mainly due to herd immunity. So we're actually seeing an impact of this vaccine 8 years later, and this impact is a 71% decrease in our 14 to 19-year-olds and a 61% decrease in 20 to 24 years of age. So an overall vaccine effectiveness of 83%. Hard to argue that, but it's taken 8 years, and in 8 years we've seen this remarkable decrease. And this is just a slide that's showing this. So if you take a look at the 14 to 19-year-old age group, a 71% decrease in the prevalence of our 4 HPV strains. The 20 to 24 years of age, a 61% decrease. We're actually noticing a decline in the older age groups, but it's not yet significant. Again, more warts that are preventable with the HPV vaccine. So genital warts was another early outcome that we were hoping to impact. And this is data from Australia. So Australia launched the vaccine in about 2007. So the dotted line in the center demarcates exactly when they started. So to the left of the dotted line, we see the incidence of their genital warts, pre-vaccine era. To the right, we actually see a marked decrease in the incidence of genital warts. Specifically in less than 21 years of age, we see the marked decrease, and then in women and men in 21 to 30 years of age. The interesting part is that for the men, even though we're seeing that decrease, this was the impact that the vaccine had on men, and the men were not even vaccinated. The males were not vaccinated, but we're seeing the impact of the women being vaccinated and the decreased prevalence of the strains directly impacting the decreased prevalence of the strains in the unvaccinated males. So in 2015 in Lancet, they reviewed 20 studies in 9 high-income countries and did a systematic review and meta-analysis of the impact of HPV in our entire population, and not just the United States. In all countries that had a greater than 50% coverage with their HPV vaccinations amongst 13 and 19 years of age, they were able to demonstrate a 68% decrease in their HPV 16 and 18 strains, as well as a 61% decrease in anal genital warts. And again, the impact of herd immunity cannot be minimized. And we also feel that there's some cross-protection. So if you are covered by those 4 strains, that you might actually get cross-coverage with other strains not covered in the vaccination. So herd immunity is so important because by immunizing a critical mass of our populace, we're actually able to protect an entire community. But this requires high immunization rates. But the importance of herd immunity cannot be minimized when we're talking about vaccinations, because we know that there is a subset of people that are just not going to get vaccinated. So by actually vaccinating many, we're actually able to protect the entire population if possible. So in the U.S. Healthy People 2020 objectives, the goal is to actually reach an 80% vaccination compliance of both boys and girls aged 13 to 15 against HPV. So we know that HPV is causing almost all the cases of cervical cancer and 91% of anal cancers. Is it doable? Absolutely. Our Tdap rates are almost 90%. Our Menactra rate is 81% for both boys and girls in the same age group. So it is possible. And the importance of herd immunity is that we need to reach at least 70% of our girls being vaccinated. And if we can't reach that target, then we need to continue to vaccinate our boys. And you saw the remarkable impact in Australia with the genital warts. The males were not even vaccinated at the time, but we saw the incidence of genital warts decrease because the females had been vaccinated. So this is actually an international study. So this was published just in November 2017 in the Journal of Infectious Diseases. And again, Australia had started the vaccinations in 2006, and what they noticed that there was an actual dramatic decrease in their incidence of this very rare and incurable respiratory disease called juvenile onset recurrent respiratory papillomatosis. And again, it may seem like it's not a big deal. There's only 0.16 cases, and it dropped to 0.02. But again, you remember, this is a rare and very incurable respiratory disease. So if we can actually just prevent one case, we've made a difference. And Australia has demonstrated that the impact of this vaccine has gone on to decrease the incidence of this incurable respiratory disease. And this is the first international report of a declining rates in that disease since the initiation of the Gardasil 4 vaccine. So discussing this with our patients can sometimes be tricky, and so I think this is a very important aspect of what we need to discuss this today, is framing that conversation. So certainly we need to be aware, because again, HPV can be transmitted even from asymptomatic patients to another asymptomatic person. So very common. And again, just reminders, yes, may not cause cancer with the warts, but can be psychologically debilitating. And yes, oropharyngeal cancer is on the rise. So if we look at our adolescent vaccination rates and our coverage, so importantly, oops, I think we lost, okay. If you take a look at Tdap and Menactra, we do an absolutely wonderful job, and I've showed you the rates before, and almost 90% for Tdap and mid-80s for Menactra. But in comparison, the HPV, the doses of vaccines, the rates are pale in comparison. And this is where we need to do better. And if you take a look at the 3-dose vaccination rates, they were dismal, 40% for females and the 30% for males. But I think the numbers would probably look a lot better, because some of these kids that had gotten 2 of their 3 may actually increase the compliance rate with the 2-dose requirement. So in the CDC National Immunization Survey in 2016, we are actually noting an improvement at least in compliance with the one dose of HPV for both males and females. We are hitting 65% for females with a single dose vaccine and 56% for our males. Overall, about 60% of our 13 to 17-year-olds have gotten one dose. However, if you take a look, only 43% actually completed a 3-dose series. So if we actually looked at all the girls that were born in 2007, by the age of 13, instead of only 47% of them being vaccinated with one dose of the HPV vaccine, 91% could have been vaccinated if we eliminated missed opportunities, i.e., if we had vaccinated when they came in for acute illnesses, i.e., when we vaccinated when we were vaccinated for Tdap and Menactra. So if we had vaccinated and did not miss those opportunities, our rates of vaccinations potentially could be much, much higher. So a study by Healy in Texas was published in Vaccine in 2014, and she compared the value that parents are placing on vaccines and clinicians' estimate of what the parents place on vaccinations, what value they place. And so when you look at the value that parents place on vaccines, across the board, they valued all the vaccines, including HPV. But when you compare it to clinicians, this is next slide, the clinicians' estimations of what the parents valued, how they value the vaccine, for meningitis, hepatitis, and pertussis, they were on par. So they agreed, yes, this is what I think the parents is, how they're going to value. They definitely valued those vaccines. But if you look at how they felt the parents were going to value the influenza, HPV, and adolescent vaccines, they definitely underestimated the value that parents are placing on the vaccine. And actually, for HPV, it was actually the worst. So they did not think that the parents valued the HPV vaccine as much as the parents actually did. So another survey in 2016 actually surveyed clinicians and asking them, why do you think our rates of vaccination so poor with the HPV? And this is coming from clinicians. The top reason was that they felt like the parents didn't think their children were going to be at risk for acquiring sexually transmitted disease, which we know is probably not very true. The parents were concerned about the side effects. The parents voiced concerns that the vaccine may promote sexual activity, and they felt that, well, you know, if I don't vaccinate my children, I'm not really harming anyone. And then they weren't convinced that the benefit outweighed the risks. So they didn't actually promote this vaccine as strongly as other vaccines. So the perceived and the real concern of the parents certainly do influence how we as clinicians recommend and administer our vaccines, even the HPV vaccine. And one of the main reasons why the parents did not initiate HPV vaccination series is because the clinician did not recommend it. So we know that one of the main reasons that a parent will decide to vaccinate a child is if the clinician gives an effective recommendation to vaccinate with that particular vaccine. So moms in a focus group definitely said that they trust their doctor wholeheartedly, and as long as they received a recommendation from that doctor, that they would vaccinate their child. So what's an effective recommendation for HPV vaccination? So the same way in the same day. So this is really important. So you should recommend that your child be vaccinated with the Tdap, the Menactra, and the HPV vaccines all together bundled. So the same way that you would recommend the Tdap and the Menactra is exactly the same way you would recommend the HPV vaccine. And on the same day. There's no reason to separate these 3 vaccines. So you would give them on the same day in the same way you would be giving the other 2 vaccines. So again, the message would be that today we're going to give you 3 vaccines that protect against meningitis, HPV cancers, and pertussis. So the emphasis is on cancer prevention. So who's done the best? So when we look at best practices, and this was published in Pediatrics in October 2016, Denver Health, which is an integrated urban safety net health system that provides care to over 17,000 adolescents per year, they've done it the best. So they've actually been able to demonstrate that they have vaccinated their adolescent boys and girls. At least 90% have received at least 1 HPV vaccine, which pales in comparison to our 60% national rate. And the population most likely to receive the 2 or 3 dose vaccine series are girls, Hispanics, those are over 20%, 200% poverty level, and non-English speaking boys and girls. So how did they achieve the higher vaccination rates? First, they bundled the vaccines. They did not separate them. So they offered all 3, gave them all 3 on the same day. And they had strong recommendations. Number 1, they strongly recommended it. They implemented it at a school-based health center. They used standing orders, so there's no confusion about how the order should be written. And they did not miss any opportunities, like we said, offer at each visit, whether it's for health maintenance or an acute visit. And they looked at the vaccine registry, made sure that if the person was delinquent for any vaccines, that they would know about it because they accessed the vaccine registry. So why does your child need the HPV vaccine? These are very common questions. Because it prevents cancer, so let's start the HPV vaccine series today. I'm worried that this will encourage my child to have sex, and so far there's absolutely no data to support that your child will become more sexually active as a result of this vaccine. So why do boys need the HPV vaccine? And we discussed this because it definitely decreases the incidence of cancers caused by HPV, including penile, anal, and oropharyngeal cancers, and prevents genital warts as well. And we only want the vaccines needed for school. And this is a common request. I don't want anything that my school does not require, but we know that all the vaccines required by school don't always recommend what the CDC is recommending. And most of them are actually reflective of infectious diseases that are communicable immediately, the flu vaccine, the Tdap, et cetera. So would you get the HPV vaccine for your children? So I can honestly say that yes, all 3 of my children have had the HPV vaccine, but more importantly, we know it's being endorsed by the AAP, the AAFP, the NIH Cancer Center, and the CDC. So all recommend HPV vaccine. And should I be getting the HPV vaccine if my child was already vaccinated? So if your child already completed the Gardasil 4, there's no recommendation to booster with the Gardasil 9. And certainly recommendations later may change, but at this point, no. But the 4 most important strains were covered in Gardasil 4. So when do we need to come back? So it depends. So if your child is younger than 15 and initiated the series, then we'll see you in 6 to 12 months. Make sure that you make the appointment with a nurse and put it on your calendar. If they're already 15 and initiated at 15 and older, then it's a 3-shot series. We'll see you in 1 to 2 months. Put it on your calendar, and then the 3rd shot will be 6 months from the 1st. So if a parent does decline today, it's okay. That's not going to be the end of the world because you can always revisit this. The most important thing is you have the child's safety in mind, you have their child's health in mind. So try to end the conversation at least one action you can agree on. So at any time, keep that communication open. Say, at any time if you change your mind, please come by, we'll give the vaccine. So if a parent doesn't say yes today, ask them, make sure that you understand why not. Acknowledge that yes, the parent's the parent's decision is the ultimate, but that you definitely applaud them for considering the risks and benefits, but that you also have their best interest in mind. And certainly advise, give them information and make your official recommendation that you certainly do advise that they get this vaccine for their child. So make sure that you are going to immunize at every opportunity in order to ensure all your patients are protected. You're going to use standing orders, and using prompts from your EHR and reminders and recalls are very, very helpful. Keep your staff all on the same page. So this is a cancer prevention mission that we should all be sharing. So make sure the staff are all saying the same thing. And this is very helpful, this tip sheet that's provided by the CDC on those same talking points, talking to parents about the HPV vaccine, answered many of the questions that we just discussed. So educate your staff about the formal recommendations, and certainly use this tip sheet as talking points. So again, the CDC does provide invaluable free information on its site that you can access at any time. And so if you have any questions at all, then certainly hopefully my PowerPoint has been helpful, and you can rely on that. But the CDC is always putting forth the most accurate, up-to-date information about all their vaccinations. For fact sheets, they're available both in Spanish and English, readily available, so you can distribute those to the parents, especially if they have any questions. And I love this cartoon, so it's not that I don't trust you, Kevin. I just don't trust the women you've been with, the men who've been with the women, who've been with the men, who've been with the women you've been with. So again, CDC, remarkable with their information they can provide. And again, HPV vaccine is cancer prevention, and we all need to rally around this vaccine and prevent all the cancers that we know are related to HPV. So if you have any questions, again, go on the website. This is part of my family. My son's missing, but I highly encourage that if you have any questions or concerns, please feel free to ask. I'd be more than happy to answer any questions you may have.
Very good, thank you, Doctor. That was wonderful, and I now know why everybody in Louisiana is always excited to have you do a presentation. Couple things as we move forward. We've moved over to the evaluation, so we'd love to have folks answer those questions. We know we're a little over time, but that's okay. Hopefully folks can stay on as we go through a couple other things. There are some questions, a lot of them you've done, but I think that might be important to answer a couple. Recently some folks have seen recommendations from speakers that say if you had Gardasil 9 that was fully vaccinated, now you should do the quadrivalent series. And can you go over that recommendation again about how that's necessary or unnecessary?
So if you have the Gardasil 9, there's no reason to do Gardasil 4 because the 4 strains are in the 9 series. So that would be redundant. And so there's no reason to revaccinate with another vaccine. And actually, Gardasil 4 is no longer available. They completely phased that out in 2016. So are we talking if they had the Gardasil 4 to then give the Gardasil 9?
Yeah.
Okay, so there are no formal recommendations. So if you started with Gardasil 4 and you haven't completed the series, then certainly if you're missing one of them, then certainly you can use the Gardasil 9 because Gardasil 4 is not available anymore. But if you actually finish the series and your child received the 3-dose series, there is absolutely no recommendation at this time to give the Gardasil 9. So if they finish the series, you don't booster. There is no such thing as a booster at this point.
Very good. And can you go over the recommendation for if you start the 2 series below 15, but then for some reason when you get the second one, it's really after 15. How does that 2 to 3?
Right. So as long as you start the first vaccine before the age of 15, then you finish it off with a 2-dose series. It's only when you initiate the series at 15 or older that you have to do a 3-dose series. So it's just like hepatitis B. If you let more time elapse between the first and the second, you don't repeat a series again. So as long as you initiated that first dose before the age of 15, you finish it off with a 2-dose series. So the best example is, suppose your child is 14 and a half or almost 15. You started it at 14 years of age, then you just wait 6 to 12 months and they get their second dose, but they probably will be 15. But that's fine, absolutely fine, because you initiated it before they return 15 years of age. So it's the initiation date, the initiation year, that's the most important to determine whether you're going to complete a 2 or a 3-dose series.
Great, thank you. Can you briefly go over again the contraindications for HPV, and is leukemia in that list?
So anyone who has, yes, because they are immunosuppressed. By definition, if immunosuppression could be chronic prednisone use, so if you have a severe asthmatic. So if you're immunosuppressed with chemotherapy and radiation, then that's a contraindication. So they would actually not, it's not a contraindication. It's a reason to get the 3-dose series, not the 2-dose series, because their immune response is considered possibly inferior. So the only contraindications is if you had a prior allergic reaction to Gardasil, or if you're allergic to yeast, or if you're pregnant, or if you have a severe illness like high fever, 104, 105, severe febrile illness. So the list of the immunocompromising conditions are those that have decreased T and B cell immunity. Those are the patients that require a 3-dose series, not the 2, because the 2 doses may not provide them the antibody response that they need. And so we're considering that their body's not able to provide enough antibodies to protect them. So they should get the 3-dose series regardless of when they start the vaccine.
Very good, thank you. We do have a question about trans men.
Mm-hmm.
Briefly, you talked about trans men as one of the groups that might be more at risk.
Right.
They're wondering if you could talk a little bit more about HPV and trans folks mainly, any known disparities between trans and cis, any increased issues, those sort of things.
So I think the recommendation there was more to allow the transgender, males and females and especially men, because we're talking about the age that we're extending it to allow them to have access to the vaccine through 26 years of age rather than limiting. And potentially it's more about transmission risk, but there's no specific data on that group. So this was just a recommendation for, quote unquote, the potentially higher risk group sexually to allow them to have access to the HPV vaccine for a longer period of time. Now, even though the recommendation is through 26 years of age, there's no guarantee that insurance will allow that to be covered through 26. And that's a real sticking point for almost all vaccines. So depending on insurance carriers, some insurance carriers, and Medicaid is one of them, may not allow you to extend even past 18 years of age. So you have to be very careful, and before you initiate that or provide that vaccine to the adult, make sure that their insurance is going to provide that coverage, because that could cost them $150 or more out-of-pocket expense.
Very good. I'm going to do 2 other questions since we are over time, but I know there's a lot of interest.
Sure.
What would you do with a 22-year-old male who received the 3 doses but is now immunocompromised?
So they're done. So if they've already received it in the past, then there's no booster as of right now. So you wouldn't reinitiate another series. You're hoping that whatever antibody response they received before they became immunocompromised is sufficient to protect them. But again, we're certainly recommending, because we don't genotype men. So men are not genotyped, and we don't know what strains they're actually covering. So we assume that if they have genital warts, then it's 6 and 11. Again, that does not go on to cause cancer. Warts do not cause cancer. So many times the men are, unless they have overt signs like anal cancer or pharyngeal lesions, we don't know what strains they're carrying. And we don't test them for that. We don't currently test if you're asymptomatic at this point. So the hope is that prior to their immunocompromised status, that they will have developed a sufficient immune response at that time to protect them for at least 10 years. And now we know that there's waning immunity potentially because all vaccines wane in their efficacy. So hopefully at that point, whatever strains he has and will not go on to expose himself to other strains that he may not have coverage with. So protected sex as much as possible.
Very good, thank you. And our last question, and I have heard this in other presentations, are there any recommendation changes if an adolescent reports to you that they are sexually active?
So if they report so as far as when to initiate the vaccine?
Yes.
So that's an interesting question. So I am going to say if you're having intercourse before 11, that is a problem, and there may be some abuse there, right? I mean, that's definitely rape, unfortunately. So I would start the series as soon as possible in those cases because we're recommending at 11 or 12, and if you're sexually active before then or even at 11, and that's early, I would say initiate as soon as possible because we know that they, possibly are already being exposed to certain strains, and we don't know what type of ongoing activity they may continue to have and expose themselves, so as early as possible at that point.
Very good. Well, thank you, Dr. Lowe. Really appreciate the presentation today and your answering all the questions. It's always great when a presentation